Thank you, Dr. Sammons. Appreciate that so much. Tonight, the Ogden Surgical Medical Society partner Ogden Regional Medical Center Pickleball Tournament still has a few openings at the Pickler in Uinta from 6 to 9 tonight if you're a pickleballer. Also tonight, the Thursday night dinner is sponsored by the Ogden Surgical Medical Society partner Ogden Regional Medical Centers with the Peter Breinholt Band is still open for more reservations here in the Shepherd Union Ballroom starting at 6:30. So please see the staff at the registration desk. The limit is one conference per attendee plus one. And also, if you've not signed up for the OSMS partner Common Spirit Holy Cross Hospital in Davis and Tanner Clinic Family Night at the Ogden Aquarium and Wildlife, formerly known as Sequest, Friday night, tomorrow night at 6:30 to 9, you can also sign up at the registration desk. We have one final speaker for this evening, and that is Dr. Bjerken. Dr. Bjerken is sponsored by the National Kidney Foundation of Utah and Ogden. Dr. Bjerken completed his undergraduate degree in Northwestern University and his medical degree at Tulane University School of Medicine and his general surgery residency at the Medical University of South Carolina. Dr. Bjerken is a dialysis access surgeon and founder of McLeod Health Loris Dialysis Access Center in Myrtle Beach, South Carolina. He is presently at a National Nephrology CME conference in Denver, where he spoke this morning. Dr. Bjerken grew up with his summers here at his uncle's ranch in Tremont, in Utah, and maybe one day we can convince him to come lecture here in person. Please welcome online Dr. Bjerken.
Thank you, thank you. Can you hear me yet? Am I audible in the room?
Yes, you're audible.
Okay, thank you. So yeah, thank you for that introduction. And I'll just say, as a general surgeon who does only dialysis access, I'm passionate about these patients, and I will cover all these topics as you see on the title slide, and certainly have room for question and answer at the end. And my goal is to impact your practice in some way and help you to understand the nuances of access for dialysis. I also am a consultant for DaVita, Vantiv, and a couple other companies. I don't serve to certainly to promote anything, but just teaching techniques to surgeons and other proceduralists. So I think it's worthwhile looking at a bit of history. The first dialysis way back in the early 20s, first challenge was finding a way to accomplish that with a dialyzer, and then the access for dialysis became a significant focus. And you look into the 60s was when there was a Scribner shunt placed in the radial artery and a cephalic vein at the wrist. And about that same time was when renal transplants came along, and I think that's pertinent to see the parallels. But catheters were then used, femoral artery, femoral vein, then finally femoral vein to femoral vein. And the first fistula was created in 1965, and it's only 7 years later did we have the ability to have enough patients on dialysis that it caused the hospitals and insurance companies to create Medicare entitlement. And before that, surprisingly, there were what were called God committees, selecting patients who could or did not get to receive dialysis. We now have grafts coming along in the 70s, the National Kidney Foundation in the mid 90s, and then the Fistula First initiative was pertinent in the middle of my career. And I will just say that there is tons and tons of innovation in this space on the surgical side. History also, decade by decade, of the numbers of patients with renal failure. And as you see in the 2020 data, 71% of 800,000 on dialysis, and pretty good number, 29% with transplants. This slide is worth taking a little time with. The expected remaining lifetime by age and sex And so you can find age on the left, patients with dialysis, patients that have a transplant, and then of course the general population. And it really, for me, is humbling to see with a patient on dialysis, even a young woman, let's take a 30-year-old woman, 12 and a half years of life expectancy from that point going forward. And so that kind of information helps us to not only have compassion for these patients and work hard for them, but also to realize when we're trying to choose what the right access might be, that their life expectancy comes into play with that decision making. So the National Kidney Foundation has the KDOQI guidelines, clinical practice guidelines for vascular access from 2019. And the mantra now is the right access for the right patient at the right time for the right reasons. And that's a far stretch from what we had before with the Fistula First initiative in 2004. And we kind of pretty readily learned that that was creating too many catheters for too long. So we started talking about fistula first, catheter last, and now we have what you see there in the middle. And it's augmented by encouraging our nephrologists to have a life plan, a patient life plan, access needs. And as a surgeon, what that really means for me is not just thinking about what access we need to create now, but what are the contingency plans, access number 1, 2, and 3 for the patient. And that, of course, includes things like PD and transplant. So from top to bottom, it would always be preferable to receive a transplant. PD has significant advantages. Fistulas tend to last longer than grafts in general, but sometimes the graft and sometimes even a catheter is an acceptable access, although it does lie still at the bottom of the list. I want to point out that that our nephrologists are held to many, many metrics, and just respect that they get dinged for how many catheters are in any given center. Any given patient has a 90-day deadline where they're expected to try to get that catheter out. Percentage of fistulas. Excuse me?
Can you please reshare your screen?
Oh. I didn't know that. How did that happen? Let me see. Sorry about that. I didn't touch anything to make that happen. Are we there?
Is that good? That's looking better. Thank you very much.
Sorry about that. So just talking about the metrics that our nephrologists are tied to. Home penetration for home modalities. Target is 25%. Nationally, that really stands at about 15%. Optimal start, starting without a central venous catheter, and that ideally that might be PD. So let's talk about peritoneal dialysis first, and we'll talk about hemodialysis after that. Historically been quite underutilized if you go back decade by decade. The training is not sufficient. A general surgeon coming out of 5 years of training will have done 5 cases. That's a national statistic. Catheters have dysfunction. 10 to 15% will occur with some kind of catheter malfunction that you have to handle, and that can be frustrating. And then there are significant supply needs that are not expensive, but there's more than might be initially understood. And as my largest nephrology practice referral says very happily, everything we want is urgent. And that being said, there are huge benefits. So there's reason for optimism that the PD has significant benefits. There are best demonstrated practices that are defined by organizations like the International Society of Peritoneal Dialysis and SAGES. These metrics that we looked at are definitely driving change, and there's really, really good teamwork amongst the various specialists in this space, as well as the corporate structures DaVita, Vantive, and the companies that make catheters. As a surgeon, I had no idea early on the power of the residual renal function. You would normally think of PD as something that includes higher quality of life measures and lower cost. But as an example, their survival advantage is that for every 250 cc's of urine a patient continues to make, there's a 36% decreased mortality. And that includes then decreased hospitalizations. And anytime we can avoid a central venous catheter, that's ideal. And they can actually get Medicare from day one of therapy if it's an optimal start. So there can be retroactive funding for them with their Medicare coverage and better outcomes at transplant. This is a data set to tell us that patients who receive modality education will make educated choices. That they may be in the yellow in the lower half. Those who did receive versus those who did not would be almost 3 times more likely to choose a home modality, twice as likely to have an access in place when they need to start, and even have lower hospitalization and lower mortality. So nephrologists are tuning into modality education. But here's, I think, really the compelling look at the difficulty. In green there on the left would be 100 patients in the nephrologist's office who get modality education, choose PD, and all start dialysis. So excluding anybody who may have got a transplant or passed away, less than half of them get to start on PD. Things happen with the renal function that come precipitously, whether they needed a heart cath or get a pneumonia, and all of a sudden they are landing in the hospital. And that gap of more than half the patients who literally were educated and wanted to do PD didn't get to do so. It could be filled with some of these getting an urgent start catheter, which I'll define in a moment, but the embedded catheter actually has significant advantages. So let's talk about how how patients will start on dialysis. Surprisingly, 60% of patients who progress to renal failure do not have a distinct plan, and they essentially crash into the hospital for dialysis, and 80% are going to be starting with a hemodialysis with a central venous catheter. And the impact of that is more far-reaching than we would like to admit. In other words, if you have 100 patients here on the left starting with a central venous catheter, a year and a half later, at least 15% still have a catheter, and very few can get converted to PD despite those advantages. And it's also not automatic to get a functioning, usable hemodialysis access that quickly. So really want to emphasize giving these patients the option of PD. So there are 3 different ways catheters are placed. There are 3 or 4 different proceduralists that do this, and then there's 3 different timelines. Open surgical is really not used much. Surgeons are adept at laparoscopy, and there's certainly big advantages for laparoscopic placement. Percutaneous is certainly done increasingly so, as you see there, interventional nephrologists and interventional radiologists are in this space. Surgeons could include vascular surgeons, general surgeons, and even transplant surgeons. I would say general surgeons have the most experience with laparoscopy. And then there's 3 different timelines. Urgent start at the bottom there, meaning starting with a patient having dialysis immediately after placement of the catheter. Here's a better look at those 3 to compare. Routine start or conventional start means a referral to the surgeon from the nephrologist. They get a catheter placed as an outpatient. There's a couple weeks of healing, a couple weeks of training, and then they can be off and using it. And then the embedded catheter choice means predicting that a patient may be less than a year from needing dialysis and putting a catheter in before they need it, just like creating a preemptive AV fistula on a stage 4 or 5 non-dialysis patient, and having that catheter ready to be used at the time that they suddenly need it. I'll say that from the standpoint of the surgeon, all three of those are essentially the same. The only difference is for the embedded catheter that there's one extra step to bringing that catheter out when it's needed. So looking at this pathway to PD for patients, on the left, urgent start, placing a catheter and using it right away, routine start, with a catheter placed more electively, but the patient needs to use it within a month or so. And then the patients that crash, and then patients that may be converted from hemo to PD while receiving their in-center dialysis. And then finally in yellow, the embedded catheter choice really has, again, significant advantages. So although urgent start may help certain patients who crash land in the hospital and need dialysis now, there are certain things that are disadvantages to that. There's risk of pericatheter leaks. So we do things like put a suture around the catheter at the fascial entrance and a long oblique tunnel through the muscle so that the catheter has less chance of pericatheter leaks. But even so, there's some restriction where they must have lower volume supine exchanges and even dry periods to promote the healing of the catheter. So in a patient who now has landed in the hospital needing dialysis now, you may not be able to deliver the amount of therapy that the nephrologist would usually prescribe. And again, depending on their body habitus, that can be difficult. So compare that to an embedded catheter choice where when the catheter is externalized and maybe they still crash into the hospital, but the catheter's there, when that's externalized and used, they could have full volume PD with no break-in period. And there's no risk of that pericatheter leakage because the cuffs are healed, and there's actually data around that less exit site infections. Beyond that, when a patient has a outpatient laparoscopy for placement of this catheter, when they're stage 4 or 5, not on dialysis, they're a much better anesthetic risk. There's time for pre-op clearance. It's convenient for the patient timing, the surgeon timing, the OR timing, when oftentimes OR availability is difficult if you're thinking about an urgent start and asking your surgeon to fit that in. So the patient's in better health. And from the nephrologist standpoint, with their metrics, they can certainly potentially as much as double their home penetration or their numbers of patients on PD. The externalization procedure is a small thing. It's not what I would have described as a surgery in the sense that it is can be done with only local anesthetic. It can be done in an office setting. It can be done at bedside or in the OR or in an outpatient-based lab or ambulatory surgery center even. There's codes for it, so it's reimbursable. I mentioned the ISPD guidelines. The International Society of Peritoneal Dialysis largely serves nephrologists and how they deliver peritoneal dialysis therapy, but there's a great resource for surgeons and those who place these catheters. And so this represents the 2019 update, which includes decades of meta-analysis of all the available data of how to place catheters, how to avoid some of the complications that can occur, minimize them, and as the language that they use for simplifying things to the surgeons are best demonstrated practices to follow. I'm in South Carolina. People are not as fit as they might be in Utah here, and so one of the difficulties can be how do we place this catheter? Make sure that the tip is in the pelvis functionally, but where should this catheter exit so the patient can work with it and see it and still have a functional catheter? So a surgeon has to have the understanding of allowing an exit site that might be in the lower abdomen with a catheter with a pre-curved bend in it, in the mid-abdomen, sometimes with extension systems to the upper abdomen, and even pre-sternal catheters. So there's an inventory of catheters that are needed to do this well. Catheters look like this. You see here, there's catheters with coil and straight tips. Neither one is preferable or better than the other in the studies and data that we have. The straight intercuff segment catheter that you see in the top left, and then the pre-curve bend are both needed depending on where the exit site is needed for any given patient. And each of those shapes come in 3 different lengths by all the manufacturers that make them. So again, a supply point of view means you do need both shapes, both lengths, or at least 2 of the 3 lengths, and then this extension system so that you can tailor the exit site location for a particular person with the body habitus and still get the functional tip properly in the pelvis. So I'm going to describe some of the surgical details enough to help you understand what your surgeons should be doing. And each catheter manufacturer has a stencil system that allows us to measure, basing off the symphysis pubis to help us make sure we get the coil tip in the pelvis, the deep cuff in the rectus muscle where it belongs, and then we choose an exit site according to the patient's body habitus so that they'll have an exit site that's not in a belt line, not in a skin fold, that they can see if they're sitting looking down at themselves to take care of their catheter. So here on the left is a catheter that's been placed, and as it comes out here, that would be a conventional or routine image where the catheter would then be ready for urgent or conventional start. Then if you have been asked to embed this catheter, it looks like what you see here on the right, where you've made a small incision where it will ultimately have its exit site, and then a secondary incision down in the lower abdomen. And then the rest of that catheter is all buried under the skin with no maintenance. You pack it with heparin solution, and it's ready to go when the patient may suddenly need it in the future. The advantages of doing this laparoscopically are that we can tunnel the catheter more obliquely and have it biased to the pelvis so that functional tip stays down and has less risk of being distracted into the upper abdomen. Surgeons can do these 2-piece extended systems. We're recommended to repair any hernias as a part of this, and even any unsuspected hernias. If you see laparoscopically an inguinal hernia, it's recommended to repair that because with PD, that will get bigger. And while the catheter is healing, particularly in an embedded situation or even a conventional start, you can have repaired that. We do things like adhesiolysis and omenopexy to help augment catheter function. And then also the colonic appendix epiploica sometimes are a deterrent to easy drainage. And more often that is a rescue procedure when a catheter has been found to be tied up with those and is part of a secondary procedure. I want to mention acute kidney injury. Since 2025, just last year, Medicare has authorized using peritoneal dialysis for acute kidney injury. And it makes sense. If a patient has that diagnosis and there's some chance of them recovering renal function, then why wouldn't we want to use PD where they have augmented or preserved residual renal function, not only over a higher amount, but also for a longer period of time. And so we don't have the nephrology world doesn't have a lot of forward data on whether PD actually augments the numbers of patients who can get off of dialysis yet. But the point I want to make is that and the data does show in general that AKI patients, 25% will recover function. And what's included in that is that you don't necessarily have to remove the catheter that they had, and you can secondarily embed a catheter that was in use, maybe not in use anymore. Maybe the patient has some degree of risk of needing dialysis again. And so rather than remove the catheter, you can actually revise it in a way that you remove the part that's been outside the body. You certainly wouldn't implant anything of that, but then you can reassemble a new sterile segment and tunnel it out to a future exit site and then embed that. So it's not something that your surgeons have probably been exposed to, but these are the sort of things that are coming along with the nephrologist preferring an embedded catheter algorithm. We said that PD catheters will have a certain degree of malfunction. The body recognizes something foreign, and 10 to 15% of the time, that'll show up. Constipation is the first, second, and third reason for catheter drainage problems, and PD nurses are adept at helping patients resolve that. And TPA is sometimes used if a catheter is not draining, but we'll just say that these patients, if their catheter's not draining, they're not getting their therapy, and so you pretty much have to look. And so we'll get a referral from a nephrologist or a PD nurse saying that the catheter's not draining. We put them on for laparoscopy. It's an outpatient procedure. And any one of these things that you see at the bottom will be found. And it is, as a surgeon who's gotten used to the fact that this is part of helping these patients continue that modality, it's kind of fun to see what it is this time. And it's not necessarily anything that's difficult to resolve. It may be the omentum, maybe adhesions of various things, and usually we can resolve it immediately and let them get back on their therapy that night or the next night. This is just a photo image of laparoscopy with the catheter there to the left and fibrin that you literally have to pull out of the catheter. The catheter is otherwise free and in good position. This is what the omentum looks like when it wraps around a catheter, and the bigger picture shows the omentum down in the pelvis. And when we see that, we definitely, at the time of an initial procedure, would do what's called an omentopexy, to just tack the omentum up and get it out of the way preventatively. That's probably needed at least 30% of the time in placing catheters initially. Infections occur, and this is initial image of a catheter with cellulitis and what turns out to be an abscess at the superficial cuff. This patient was otherwise doing well on their PD, maybe have just lost their acumen with their exit site care. So not nice to have to see all this, but just to give you a nice sense of what we do, you can expose that and size and drain, expose the cuff that's abscessed, and in this case, it was not tracking any deeper. So we could leave that catheter in, not have to remove it, let them continue their PD. You can see the fluid in the catheter is clear. And then over time, that goes on and heals. And the cuff is exposed, and you can shave that background off the catheter carefully. Now you've got a one cuff catheter, which is less than ideal, but this patient did not have to have a surgery to remove the catheter, and could continue their therapy, and hopefully learned a little bit of the nuance that failed their exit site care. So superficial cuff access, not necessarily requiring removal. Let's switch to talking about hemodialysis access. The realities of this are kind of sobering in the sense that oftentimes the care is shared between multiple subspecialists. Vascular surgeons and general surgeons do the creation of these, interventional radiologists, and you would be aware of interventional nephrology as a well-established subspecialty. And they can do some of the maintenance and salvage of these catheters when there's percutaneous needs. But most often, vascular and general surgeons do not use this as a large part of their practice, and it's really not a priority. It's an add-on to some otherwise complex vascular surgery practice generally. Surprisingly, vascular surgeons coming out of their added training have the number nationally is 24 cases of access work, which really doesn't amount to any significant experience given the complexity of this. Best practices tend to be fairly poorly defined or poorly understood. And again, everything has a sense of urgency. And with fistula and grafts, we're really continuously managing against failure. We'll come back to that image and we'll use that as a clinical example. The bright side of this is that you saw those numbers of incidents of patients with renal failure. There's growing need. There's a lot more to this than you would expect. I think it honestly takes about 10 years of doing a lot of this to truly understand and become humbled by what it takes. There are good algorithms and standards, and it brings forth a lot of creativity. And this longitudinal care with these patients, so that's rewarding. Get to know them, and it's a good service to that patient population. And there are good organizations. Actually, the Vascular Access Society of the Americas is meeting next week in Salt Lake City, so we'll be there. So it's a very rewarding practice, and I would just say that this is data on central venous catheters. Twice as likely to have hospitalizations, 2 times mortality, 4 times risk of infection. So, fistula first, catheter last was leaning in that direction, but the right access for the right patient, the right time for the right reasons means sometimes placing a graft or even an early cannulation graft in a patient so they can not have a long-standing central venous catheter. Some of the basics of dialysis, and you would understand that more than your average surgeon, but when we think about having an access, they want to run these patients in the in-center units at 400, 450 cc's a minute to try to lessen the time they're in the chair. The access flow to accomplish that has to be at least 600 cc's a minute. There certainly are blood pressure and cardiac output concerns that go along with this. And then there's ways that clearance and adequacy of dialysis is measured, including KT over V there, which is a measure of the fractional urea clearance. I've got just an image of a cannulation needle. 15 gauge is the largest that is used, and that stands pretty large against what you see there as an 11 blade or an X-Acto knife. So think about these patients getting stuck, their fistulas being cannulated with 2 needles 3 times a week, or doing it at home with home hemo, 2 needles 4 or 5 times a week. So how do we figure this out in creating the right access? It certainly gets tailored to the individual patient. There's a rule of 6s that I'll show you in terms of adequacy of the access, and you want to certainly move towards having the catheter out as quickly as possible, and getting something that is likely to mature, of course, and not every patient needs a fistula then. Certainly is the first choice when we're going towards hemodialysis, but depending on their vasculature and the life expectancy, they may be better off with a graft. We'll talk about early cannulation grafts to help reduce the catheter days. And even more challenging is those patients who have run through various accesses in either and both arms and even get to thigh access. So again, the question of what's next, what are the contingency plans, are always part of the thought process. If your nephrologist is looking at a 90-day timeline before they're penalized by having that catheter in any individual patient, this is sort of the optimal, and just it is hard to achieve. But our access center really is aiming at, from the point of a surgical referral, having an appointment within 2 weeks, having a surgery within 3 to 4 weeks, post-op appointments to assess maturity with ultrasound, and then first cannulation. Maybe the ideal would be at about 66 days, where we mark the access and then have their catheter out after a couple weeks of steady cannulation. Realize that these patients also will require maintenance with various triggers for evaluation. So it's not easy to get that catheter out within 90 days if you're trying to create a functional hemodialysis access. Various things that the surgeons and proceduralists should be doing, and ultrasound is definitely our best friend from the standpoint of vessel mapping preoperatively and choosing a side, right or left, intraoperatively confirming the mapping, planning your incision, and then of course the follow-up in the office is all ultrasound based on every single patient. We use a lot of anesthetic blocks. It's safer for these patients who are all ASA4. And it also creates significant vasodilation. We certainly avoid pacers, try to avoid steel with some strategies that I'll talk through, particularly being aware with these patients with hypertension and diabetes and peripheral arterial disease may have forearm vessel disease. We have strategies to treat steel. The rule of sixes is that of the depth, diameter, and flow of the catheter. And again, maintenance with fistulograms, sometimes even early, within a month or two, if the fistula isn't meeting those maturation guidelines. And whether it's a graft or a fistula that has to be superficialized or transposed, it's all about the tunneling and having it really close to the skin for the technicians to use. When we think about any access, whether it be a fistula or a graft, there's basically three components. And this is helpful in both creation and maintenance and salvage. The inflow, of course, is the arterial side of things, looking out for PAD. The outflow means centrally, largely, but let's say if you've got a forearm fistula, the outflow is really what's going on from the upper arm and proximally, and then the conduit. What is it that we're going to be sticking? Is it a vein? Is it a graft? And when you think of malfunction, you can pick out which one or two of these is really the problem. Is it a conduit problem because of pseudoaneurysms in a graft, or is it stenosis in the vein, or is it really just inflow and PAD or stenosis in the inflow aspect of an access? So along with that series of understandings of any given access, an access goes through these modes of creating, maintaining, sometimes salvaging, and then sometimes abandoning and going on to the next thing. And so when we are doing any procedure on an access after the creation, it's as a surgeon, I'm thinking, okay, but this is salvage mode. Whatever it takes, I think we can still salvage this during, say, a declot, and all bets are off. Sometimes it's less often that we are faced with having to abandon, but we try pretty hard. This is our mapping worksheet, and just to point out that from the bottom line, we're just at least choosing an arm. We'd like to predict one or two choices of preference, and it's a matter of also relaying a lot of pertinent information of these patients as far as not just diameter and depth of the veins, but pulse exam and the arterial assessment with triphasic, biphasic, monophasic calcifications, PAD. Patients that have pacers, we want to avoid the side of a pacer. So, in the pre-op visit, the office evaluation is pretty extensive and supported by this mapping, so that we can all share an understanding of what we chose and why. Fistulas can be constructed in many different ways: a radial cephalic or even a snuff box fistula at the wrist. Fistulas in the upper arm with either the cephalic, upper arm cephalic vein or basilic vein. The artery part could be the brachial artery. So I've got here BC is brachiocephalic, MC is median cubital to an artery connection, and then brachial basilic. The other thing that I've highlighted here is proximal radial artery and even proximal ulnar artery, and those come into play regularly as a choice when you're trying to avoid steel, and again, depending on the situation with peripheral arterial disease. Fistulas have to be transposed. There's different ways to do that and different words describing what that might be. There's a particular type of anastomosis that we use to lessen the risk of stenosis in that very early part of the vein, or what we call the juxta-anastomotic segment. So there's some details for the surgeons. Percutaneous fistulas, there's 2 different devices that are out there. This one is kind of on hold. Both of them are I'll just say, successful, but there's a learning curve for the proceduralists that do it, and there's a learning curve for how these percutaneous fistulas can be cannulated. So we'll just summarize by saying that it is not a golden answer above surgical fistulas that we continue to create. When we do anesthetic blocks, it's very common that the veins will dilate, and you may see someone who's thought to have insufficient veins for a fistula, plan to place a graft, but we can find that in the OR under supraclavicular block, they can have a radiocephalic fistula all of a sudden, or some other choice. So we definitely always redo the ultrasound and strategize and maximize our choices with that. Our nephrologists are pretty adept at sending patients for stage 4 and 5, a preemptive fistula. They're not on dialysis, so this would be a quote unquote fistula only referral. And so if the patient has too small of veins and it looks like their real option is only a graft, you have a choice to either have them wait until they're closer to needing dialysis. You would not put a graft in a patient that's not going to use it right away. Or you might, depending on your instincts, have them go to the OR with a block and hope that you could create a fistula with the vasodilation that you receive. And so there's that to be taken into account. And I'll point out at this point that you all will see patients with varying stages of renal insufficiency, and sadly, many patients do crash into the hospital not knowing they had renal insufficiency. But anybody with stage 4 or 5, and arguably some versions of stage 3, would definitely need nephrology evaluation. So I mentioned the rule of 6s for fistula maturity, and it's kind of like this inconvenience store that you see there on the left, where those shelves are too high for anybody to see or even reach. And so the depth of a vein or a graft that's been tunneled really matters. And so if you call it 6 weeks, 6 millimeters or less deep, 6 millimeters in diameter or more, 600 cc's per minute of flow, and then at least a 6 millimeter cannulation zone. Those of us who do a lot of this recognize that the staff and the cannulators in the dialysis units are the ones who actually get to define whether a fistula is stickable. And so we use 5 millimeters depth as a minimum. And so there's times where we're transposing nice fistulas, and if they're 6 or more millimeters deep, we really don't want to have those get banged up by initial attempts and damage perhaps. As far as AV grafts, there's a number of products out there. Bovine carotid artery was on that history back from the 60s. The PTFE has its place, and there are versions of early cannulation grafts. Those 4 different products are equally effective choices. A hero graft or a hero hemodynamic reliable outflow is really a device which is a graft attached to a venous outflow component that's really only indicated for patients who have central venous occlusion bilaterally, have run out of access options because of that. But if we can get an interventional radiologist to get access to the right atrium, you can have essentially a catheter that's attached to a graft. So everything's under the skin. And my mentor, Dr. John Ross, who's certainly the world expert access guru, will tell you that if you think you're too close to the skin while you're tunneling your graft, you got it right. It is all about the tunneling. And surgeons oftentimes will not appreciate what it takes to cannulate these things. Early cannulation grafts have technology of the various layers, and the benefits are that they can be stuck right away. In other words, place it today and stick it tomorrow. And you see in this image in the lower right how that puncture site is less damaged, essentially. So similar to the percutaneous fistulas, this doesn't take over the market. Really, fistulas are still better. And again, of course, it depends on the patient's clinical situation and their expected remaining lifetime and vascular anatomy. So there's lots of different configurations of grafts that can be placed, forearm, upper arm, and not important to look at each of these individually, but just to say that, for example, in a patient with peripheral arterial disease, say they have lacking a radial pulse, the ulnar artery may still be patent and or diseased, then you want to have that patient would generally need a graft and have that access as proximally as possible to the axillary artery or very proximal brachial artery and an upper arm loop to avoid steel. A little bit of word about catheters. The right atrium is the intended location for the tip. Very important because if it's in the SVC, it's more likely to become have malfunction. Definitely preferred to place them on the right side over the left because of the straight pathway, and that catheter can sit more quietly in the vein and have less contact across the venous system centrally, and have ideally less central venous occlusion, depending on how long it's there. There's different tip types and tunneling for that. And so there is more to it than you might initially imagine. Catheters can malfunction because of fibrin sheaths. And there's the hero graft that's sometimes needed, which can require a special type of procedure to place a catheter that would be converted to that. Here's just an example of on the left catheter that in a patient that we saw in referral because it wasn't working, and the tip is in the SVC, not in the right atrium. In the middle is an image with contrast, and that's basically a fibrin sheath, very narrow. It's like a sock around the catheter, and the catheter enters into the jugular vein much higher. You might put that in as a central line, but you can see how when it has that up and down configuration, it's prone to kinking. So this is what a catheter, when we replace that, it enters in very low, the tip's in the right atrium, and it comes out more laterally with a gentle curve and not be prone to kinking. So interventional radiologists are very skilled at this, and surgeons as well, but there are some nuances to that. Catheters fistulas or any access requires maintenance. The average is 1.8 times per year. And that's how we get to know these patients and get to know these accesses. A good access is gold for these patients to achieve good dialysis. Most often it's angioplasty. There are drug-coated balloons that come into play. quite a lot of stents that are needed when stenosis doesn't respond well to balloon angioplasty. There's all versions of stents you see available there. And then there's other issues like ulceration and aneurysms and steel that we have to contend with. An image here, this is a left arm fistulogram, brachial artery at the elbow connecting to this vein, which is the fistula, cephalic vein. There's a lateral cephalic here. And you can see all the bumpy areas of stenosis and working even more proximally, it was stenotic for quite a long ways, and actually was kept open by the fact that this lateral cephalic was receiving flow going distally, and so that was a saving grace. It wasn't competing flow. But after angioplasty, you can see how smooth and patent that is, and that lateral cephalic branch was no longer needed as an outflow pathway. It was all just going the path of least resistance back to the heart through the cephalic vein into the subclavian. So lots of varieties of disease with fistulas, and this is a left forearm radial cephalic fistula. The lower image shows a lengthy area of stenosis in that very distal cephalic vein just above the anastomosis. And after angioplasty, that looks nice and smooth, but that is the area that is most prone to recurrence of stenosis in either a forearm or upper arm fistula. So let's go back to this picture, and in just looking at the picture, I'll say that there's a few things to notice, and I'll say that one of the cool things about this access work is it really demands a close attention to history and physical exam. There are nuances that we can understand. So what's the history? Is there decreased access flow from the dialysis unit? Is there decreased clearance? Are they having difficulty cannulating? In this case, let's just say there was decreased clearance and decreased access flow. This forearm, so the anastomosis is here at the wrist on the volar side. Here's a side branch and a collateral that's also filling. This vein is pretty generous. They're using a ladder technique of the cannulation, so not spreading out the cannulation sites. And the physical exam includes looking for aneurysms or worrisome skin conditions, ulceration. If the skin is pinchable and mobile over the vein and not stuck to the vein, then that's a positive attribute. Sometimes the skin becomes depigmented and thinned out, and we have to stick on the periphery of these. But this aneurysmal area is not a problem at all. You see kind of a concavity here, and what you would notice if you were examining this patient is that the very distal part is pulsatile. It's got a bounding hard pulse, and then after this, it's got a renewed thrill here, and then it's soft going proximally. All fistulas will be softer, and if you're listening with your stethoscope, it's going to have a loud bruit at the anastomosis and softer as you go proximally. But there was a renewed thrill and bruit here, signifying stenosis right here. And luckily, this collateral was carrying on flow so that although they weren't maybe getting good dialysis for some number of treatments, it wasn't at risk of totally clotting off because there was going to be flow through that collateral. So there's also a straight arm raise. If you let them hold their arm vertically, the fistula would be full here and empty beyond that stenosis. We also look for things like edema that signify more proximal stenosis. Certainly examining the pulses and skin condition is always significant. There's a lot you can learn just by running your hand along the length of the vein, noticing when it changes, when there's a renewed thrill or bruit. Salvage procedures include, of course, declotting, Catheters need to be exchanged. As that example, that's a salvage procedure for a catheter. We have various things. We can use TPA in large fistulas where there's a significant clot burden. There's devices like angiojet and cleaner that help us to obtain a good declotting. A fistula or graft will clot off only because there is some stenosis, and usually more than one. A fistula that has one area of stenosis will hang on with flow, and yet if there's inflow and outflow stenosis, that's when you see the thrombosis. So sometimes we're stenting areas of blockage that were the culprit lesions, and then of course sometimes skin conditions wear down, or there's ulceration or impending rupture, and we can revise and bypass and do all sorts of things. And that is the creative part of this work is what do we need to do now for this particular situation? These are the complications that can occur. Steel neuropathy, peripheral neuropathy can be augmented. Carpal tunnel syndrome is more common. Patients who have diabetic neuropathy will more likely have an exacerbation of that neuropathy when a fistula is created. It has nothing to do with damage to any particular nerves. Ischemic monomelic neuropathy, or IMN, is an extremely rare form of neuropathy that can occur immediately after creating of a fistula or a graft, and is manifest as extreme pain distal to the access and requires immediate ligation of the access. It's a pretty rare complication, so not something that you're likely to see or have seen. Aneurysms, a lot of times are tolerable as they are, and there's various other things that come up that require repair. And lastly, just talking about steel, it involves looking at their arterial disease. You literally will do an arteriogram to see what goes on. There's all those forms of reconstruction to help that. Ligation is at the bottom of the answer list there, but sometimes that is what's needed. Then, of course, you're trying to figure out what to do next. All of those acronyms are relevant in that we talked about the proximal radial artery anastomosis, and that is, and if this were a left arm, brachial, radial, and ulnar, just go beyond the bifurcation and make your anastomosis there, and that lessens the amount of flow, actually lessens the risk of juxtaanastomotic stenosis, and then clearly lessens the risk of steel, as the ulnar artery, which is the dominant vessel to the hand, is left to continue to supply the hand. These are the various forms of revisions that can be done, whether it's banding or the one that's on the third from the left here is proximalization of the arterial inflow. In other words, ligating the fistula there and having it a smaller conduit, a graft segment that brings flow from higher up near the axilla, and that acts as a governor or regulates the amount of flow to the fistula and preferences the hand, but could still use the fistula right after doing that. Lastly, sometimes there are high flow concerns, pulmonary hypertension. You can have to band these. There's different ways you can band it, or you can revise with making flow more distally. If it's a brachial artery inflow, you may bypass it with a smaller graft to the proximal radial artery in the forearm even. So those are the sort of problems that we sometimes see. And I'll lastly leave you with this. We're speaking about things that surgeons would do. And, I'm still learning, after 3.5 decades of doing this kind of work. You can know that whatever your specialty is or whatever your work is, you can see that you come out of your training and you may have a initial high degree of confidence, and the world and particularly medicine will teach you lessons, and even as you get into knowing more and more of what you're really doing, your confidence never is as high as you were when you were overconfident early on in your career. And so this relationship is worth looking at no matter what we're doing. But as I talk to different surgeons, it's actually good to talk to young surgeons. They're willing to learn, and those in the middle are maybe prone to being overconfident. It's definitely a humbling process. The Dialysis Access Center for these patients is really advantageous. Patients will travel for quality and service. We see patients from over an 80-mile radius from multiple locations because we can get them in. Everything is urgent, and that's my contact information. I'm happy to share going forward if there's any questions. And Sunrise in Myrtle Beach. I'm on the East Coast when I'm home. And so thank you for your attention. I'll stop sharing. Happy to answer any questions. I think we have a few minutes time for that. I hope it's relevant to your practice. It's hard when you're not in the room. I'd love to be there, frankly.
Well, thank you, Dr. Bjerken. We really appreciate you taking time out of your very, very busy day to stay with us and give us such good information. We appreciate it. And thanks to all of you in the room and also all of you online for staying with us as well, too. We hope that you take participation in our social activities for this evening as well as tomorrow night. And we will see you bright and early tomorrow morning. Thank you for staying.